Good morning, good afternoon, good evening, everybody. I'm Ali Bazarbachi from the American University of Beirut in Lebanon, and I'm delighted to give you today this webinar of the International Academy for Clinical Hematology, IACH. I will start sharing my screen. So today I will be talking about maintenance therapy after allogeneic stem cell transplantation for FLT3-ITD AML, current status and guidelines. So as you know, FLT3 activation is probably the most common abnormality in AML, as shown in this seminal paper by Papa Emmanuel in 2016 and in many other confirmatory studies. And indeed, there are two types of FLT3 mutations. So as you know, FLT3 is a receptor tyrosine kinase with an extracellular immunoglobulin like loop domain, a transmembrane domain, a juxtamembrane domain, and the intracellular kinase domain. So we can have FLT3 internal tandem duplication or FLT3-ITD. This is the most frequent mutation in 25 to 30% of cases associated with high risk of relapse and poorer survival. Conversely, we have the FLT3 TKD or for tyrosine kinase domain mutation, less frequent, 5 to 10%. Its prognostic value is unknown, but it is known for resistance to type 2 FLT3 inhibitors. So as I mentioned, FLT3-ITD mutation are prognostic markers in AML. You can see here from multiple studies, such as this UK AML 10, 12, 15 studies, FLT3-ITD mutation is associated with increased risk of relapse and decreased leukemia-free survival and overall survival. And in these studies, the allelic ratio of FLT3-ITD was predictive for outcome. The higher the allelic ratio, the higher the risk of relapse and the lower the survival. So that was for detecting FLT3-ITD mutation at diagnosis. But even in the transplant settings, this EBMT acute leukemia working party study published by Christoph Schmidt in 2015 showed a lower leukemia-free survival and overall survival for patients with FLT3-ITD mutation. And indeed, what matters is the combination of nucleophosmin-1 or NPM1 mutation with FLT3 mutation. So patient with mutated NPM1 and wild-type FLT3 have the best outcome. Patient with wild-type NPM1 and FLT3-ITD have the lowest LFS and OS, and the other are in between. So high risk of relapse even in the transplant setting. Recently, few months ago, within the EBMT acute leukemia working party, we reported a significant improvement in post-transplant outcomes in recent years for AML patients with FLT3-ITD and wild-type NPM1. You can see that on your left-hand side. So the leukemia-free survival and overall survival was significantly better for patients transplanted between 2017 and 2021. as compared to 2012, 2016 for this subgroup of patients historically having the poorer outcome, the NPM1 wild type. Conversely, on your right-hand side, patient with NPM1 mutation and FLT3-ITD, those that have an intermediate prognosis and a better outcome, there was no change over time in post-transplant outcome, but it was already very good. And these results are quite in agreement with the European Leukemia Net ELN 2022 risk classification by genetics at initial diagnosis. As you can see, patients with wild-type NPM1 and FLT3-ITD are no more considered at high risk of disease. They move to the intermediate risk, similar to those with mutated NPM1 and FLT3-ITD. So this will tell you, like in many other hematological malignancies and in oncology in general, that prognostic factors are treatment dependent. So the prognosis of FLT3-ITD historically was poorer. It is now improving, including in patients with wild-type NPM1, because of the availability of targeted therapy for FLT3-ITD, namely FLT3 inhibitors. So to make a long story short, we have two types of FLT3 inhibitors. The type 1 that work on the active conformation, so the type 1 inhibitors, they will work on both the active and the inactive conformation. So they will target FLT3-ITD as well as FLT3-TKD, and these include, for example, midostaurin and gilteritinib. Conversely, type 2 inhibitors, such as sorafenib and quizartinib, will only target the inactive conformation, so they are only working on ITD mutation, but not TKD mutation. So, however, these so-called FLT3 inhibitors are not selectively FLT3 inhibitors. You can see here from this kinome analysis that both type 1 and type 2 inhibitors, they will not only target FLT3, but they will target many other kinases. You can see gilteritinib, a pan-kinase inhibitor, sorafenib also. Quizartinib is probably more targeting, more restricted to FLT3, but still many other kinases are inhibited. So in terms of cell biology, we don't know everything. These FLT3 inhibitors will not only inhibit the tyrosine kinase activity of FLT3, but probably of many other tyrosine kinases. So there are different settings for using FLT3 inhibitors in AML. They can be used during induction therapy in combination with chemotherapy or hypomethylating agent. They can be used in the relapse refractory setting as a bridge to transplant or continuous therapy post-transplant, continuous therapy for relapse without transplant. They can be used as salvage post-allo for hematological relapse or molecular relapse, and they can be used as maintenance prophylactic treatment post-allo for MRD negative patient to prevent relapse. So starting with the first setting, using FLT3 inhibitors during induction therapy. Historically, the first trial was the SOAR-AML trial that combined chemotherapy, daunorubicin, and cytarabine with sorafenib or placebo for untreated AML 18 to 60. And sorafenib was used during induction consolidation, and maintenance. Interestingly, in this trial, all AML patients were included regardless of FLT3 mutational status. And allogeneic stem cell transplant was permitted for intermediate risk patient with a sibling donor and high risk patient with a matched donor in first CR. So you can see here the results. Using sorafenib was associated with a significant improvement in event-free survival, relapse-free survival. The study was not powered enough to show a difference in overall survival. But the most interesting part, in my opinion, was that the improvement in EFS and RFS was not only seen for the subgroup of patients with FLT3 ITD, but was also seen for patients without FLT3 mutation, indicating an off-target effect of sorafenib that we have seen can target many other kinases. Then the practice-changing randomized trial was the ratified trial by the CILGB 10603, which was a phase 3 randomized study of chemotherapy plus or minus midostaurin. So newly diagnosed AML patient 18 to 60 with activating FLT3 mutation, so FLT3 ITD or TKD, were randomized to daunorubicin cytarabine together with midostaurin or placebo during induction, high-dose cytarabine plus or minus midostaurin or placebo for CR patient up to 4 consolidation cycles, and then post-consolidation maintenance midostaurin or placebo. Stem cell transplant was not specifically mandated, but for patients who received stem cell transplant, post-transplant maintenance was not permitted in this study. And you can see here the results. Using midostaurin was associated with a significant improvement in overall survival, with median overall survival improving from 25.6 to 74.7 months, and 4-year survival improving from 44 to 51%. So this study was stratified by the type of mutation, and you can see that the benefit from midostaurin was seen for patients with FLT3 ITD high allelic ratio, FLT3 ITD low allelic ratio, as well as for FLT3 TKD. Interestingly, for transplanted patients, you can see here patients that received an allograft in first complete remission and patients who received an allograft outside complete remission. For patient allografted in CR1, there was a significant benefit from using pre-transplant midostaurin, conversely, which indicating a synergy between midostaurin and allotransplant. Patient allografted outside CR1 had a lower outcome, and there was no difference between those who received pre-transplant midostaurin or placebo. A more recently published study was the Quantum First study using quizartinib plus chemotherapy in newly diagnosed FLT3 ITD AML. Again, randomized double-blind placebo-controlled trial. And you can see here, quizartinib was used with dono or ida plus cytarabine during induction, together with high-dose cytarabine during consolidation, as well as during maintenance. And here are the results. The primary endpoint, overall survival, significant improvement in overall survival, with median survival improving from 15 to 31.9 months, hazard ratio 0.77, significant p-value. So we have seen in these different studies a significant benefit for patients receiving FLT3 inhibitors together with induction and consolidation. What about patients in the relapse refractory setting? So this is probably not the best way of using FLT3 inhibitors. Gilteritinib is approved for relapse refractory FLT3 AML. And you can see here that patients who received gilteritinib on your right-hand side for relapse refractory AML, FLT3 AML, both FLT3 ITD or TKD, had a significant improvement with a hazard ratio of 0.64 in overall survival, but still the long-term outcome is quite dismal. Similarly, on your left-hand side, quizartinib also improves overall survival when used for relapse refractory AML, in that case only FLT3 ITD, with a hazard ratio of 0.76, again with relatively dismal long-term overall survival. We can use also FLT3 inhibitors with azacitidine and venetoclax. This use in frontline setting is associated with a very high rate of complete remission, 93% CR rate, 100% response rate in a relatively small study from MD Anderson. But for relapse refractory patients, the real CR were much lower, 19% only. Overall response rate was 69%. The third setting for using FLT3 inhibitors in AML is for salvage post-allo, hematological relapse, and molecular relapse. And you can see here in this EBMT registry study, within the pair match analysis, the 2-year overall survival for patients with FLT3 ITD AML and relapse after allo, 2-year overall survival 30% for patients who received sorafenib as part of the treatment for relapse, either alone or combined with chemotherapy, versus 14% for patients who did not receive sorafenib. P-value was highly significant. Finally, I believe the most interesting setting for using FLT3 inhibitors in AML is for maintenance after allotransplant in MRD negative patients. And we have reported in 2015, early 2015, this pilot study on 6 patients, high-risk patients who received sorafenib maintenance post-allo, and all were in CR MRD negative post-allo at the time of report of this study, including some with a relatively long follow-up. Then we performed this multi-centric study between our center at AUB, Saint-Antoine Hospital in Paris, and King Faisal Specialized Hospital and Research Center in Riyadh in Saudi Arabia. 27 patients were included, and after a median follow-up of 33 months, the 2-year leukemia-free survival was 75%, 2-year overall survival 83%. And these results were confirmed in our report by the EBMT Acute Leukemia Working Party, where you can see here that in the pair match analysis for patient who received sorafenib for prevention of relapse post-allo, so prophylactic maintenance therapy with sorafenib, the 2-year leukemia-free survival of 79.1% as compared to 53.8% for those who did not receive sorafenib maintenance. And this translated into a significant improvement in 2-year overall survival from 61 to 82.8% with sorafenib. So these results were confirmed by 2 randomized trials, the SORMAIN trial using sorafenib maintenance after allotransplant for FLT3-ITD-AML, and you can see here that patients started between day 60 and day 100 post-transplant. The primary endpoint was relapse-free survival. So this was a relatively small study that included 43 patients in the sorafenib arm, 40 patients in the placebo arm, yet there was a major improvement in relapse-free survival and overall survival. You can see here relapse-free survival improving from 53% with placebo to 85% at 2 years, and overall survival improving from 66 to 90%. So these results are almost identical to those that we previously reported in the EBMT registry. So when people criticize registry studies, actually this is one example, and I think an important one, demonstrating that you can, when a registry study is adequately performed, you can reproduce sometimes to the decimal the results of a randomized trial. In terms of safety in this German randomized SORMAIN trial, sorafenib was relatively well tolerated. We had some increased risk of skin toxicity from 2.6% with placebo to 11.9%, and some increase in cardiac toxicity from 2.6 to with placebo to 9.5 with sorafenib, but most of these were considered not drug-related. Only one case of drug-related cardiotoxicity was reported in the sorafenib arm. Overall, dose reductions occurred at a higher rate with sorafenib in 48.8% versus 40% for placebo, mainly because of cytopenia, and discontinuation due to adverse event were more frequent with sorafenib, 22% versus 5% with placebo. So the difference of 17%, almost 1 in 6 patients discontinued sorafenib because of side effect as compared to placebo once we subtract 5 from 22. Another bigger randomized trial was reported from China, this time an open-label randomized phase 3 trial at 7 hospitals in China comparing sorafenib 400 milligram twice daily versus placebo at 30 to 60 days post-transplant. And most common adverse events were infection, GVHD, and hematological toxicities. And again, you have a significant decrease in the cumulative incidence of relapse, as you can see on your right-hand side, the upper panel, with a hazard ratio of 0.33, translating into a major improvement in leukemia-free survival and overall survival with sorafenib as compared to placebo. Interestingly, the benefit from sorafenib was observed in all subgroups, regardless of pre-transplant use of sorafenib. In other terms, whether patients received sorafenib pre-transplant or not, they benefited from sorafenib maintenance post-transplant. And regardless of MRD status, whether patients were MRD positive or MRD negative at transplant, both benefited from sorafenib maintenance. And actually, in terms of mechanism of action, we have this very elegant work published from the German group in Nature Medicine in 2018, demonstrating that sorafenib promotes actually graft versus leukemia activity in mice and human through IL-15 production in FLT3 ITD mutant leukemic cells, so involving natural killer cells. So this is why the setting of post-transplant maintenance is different from the setting of relapse, for example. In this case, we are not only targeting the FLT3 kinase activity in the leukemic cells, but also targeting both dual targeting of the leukemic cells and of the donor immune microenvironment, promoting graft versus leukemia activity against FLT3 ITD leukemia. So what about other FLT3 kinase inhibitors? For midostaurin, we have the RADIUS trial, which is testing midostaurin maintenance after allotransplant and FLT3 ITD AML. So midostaurin plus standard of care versus standard of care up to 12 cycles. And primary endpoint was relapse-free survival. And as you can see in this RADIUS trial, there was some numerical non-significant improvement in relapse-free survival and overall survival. We have also data for quizartinib in the Quantum First study, which I showed before, where quizartinib was used together with chemotherapy during induction and consolidation, but quizartinib could be used also as maintenance therapy after allogeneic transplant. So this is the overall survival in patients who received allotransplant in CR1 by MRD status in the Quantum First study. You can see that on your left-hand side, that we have a numerical increase mostly in MRD positive patients. However, the 95% confidence interval is crossing 1, both for MRD negative or MRD positive patient. So there is a hint that quizartinib may improve outcome, but this was not statistically significant. Finally, a long-awaited randomized trial by the BMT-CTN group was the MORPHO trial that randomized gilteritinib versus placebo as post-transplant maintenance in FLT3 ITD AML. So this trial included 356 patients, randomizing for 24 months gilteritinib 120 milligram per day versus placebo. And inclusion criteria were subjects in CR1 more than 30 days, less than 90 days after allotransplant, with stable engraftment and without active grade 2 to 4 acute GVHD, went on to randomization. Unfortunately, this trial did not meet its primary endpoint. So you can see for the upper panels, improvement, numerical non-significant improvement in relapse-free survival. So hazard ratio was 0.67, but it crossed 1, and p-value was 0.0518, so it was more than 0.05. And there was, importantly, no difference at all in overall survival, panel B, the upper panel on your right-hand side. And indeed, gilteritinib use as maintenance decreased the relapse incidence in panel C, but increased non-relapse mortality in panel D, and overall, no difference in overall survival. So then, in subgroup analysis, you can see the upper panels are for the outcome according to the MRD status. So you can see that patients who were MRD negative had a significantly better relapse-free survival, panel A, and overall survival, panel B, as compared to patients who were MRD positive at transplant. Unfortunately, patients MRD negative did not benefit from gilteritinib maintenance. This is panel D. Conversely, MRD positive patients had this time a statistically significant improvement in relapse-free survival. But again, this did not translate into overall survival benefit. So in other terms, even in MRD positive patients, overall survival was not improved with gilteritinib. Interestingly, and this is very difficult to understand in this study, when we look to the effect of gilteritinib according to the geographic area on relapse-free survival, you can see that gilteritinib was associated with a significant benefit only in North America in panel A, where the control group had a poorer outcome as compared to the control group in Europe or in Asia-Pacific areas. Conversely, if you look to Europe, for example, in panel B, the placebo arm in red had a better relapse-free survival than the gilteritinib arm in blue. And finally, we have this meta-analysis, systematic review and meta-analysis of maintenance therapy for AML. And you can see on your right-hand side that FLT3 inhibitors improve overall survival and relapse-free survival, the upper panels in A and B, as compared to placebo or no use of FLT3 inhibitor maintenance. Finally, I would like to finish with this EBMT survey by the EBMT Acute Leukemia Working Party on practice patterns of transplant centers regarding maintenance treatment post-allotransplant in AML. So overall, 115 centers responded to the survey, and 89% of centers, so 102 out of 115, implement a kind of maintenance strategy post-allotransplant. 64% of centers use hypomethylating agent, which is not our topic today. 83.5% of centers use FLT3 inhibitors. And when we look to your right-hand side, which FLT3 inhibitor would you use for maintenance? You can see that 88% are using sorafenib, significantly higher than the percentage of using midostaurin or gilteritinib. So when we go to guidelines, these are the NCCN guidelines for recommended post-transplant maintenance. You can see that for the version 6 of 2023, patients who underwent allotransplant and meet the following criteria in remission and history of FLT3 mutation, FLT3 inhibitor maintenance is recommended. Sorafenib is the first choice, and this is category 1. And then you have midostaurin, gilteritinib, and quizartinib as category 2B. And finally, this recommendation that we made within the ABMT Acute Leukemia Working Party clinical practice recommendation on allotransplant for AML patient, a position statement from the ABMT Acute Leukemia Working Party that was published in Hematologica in 2020. Post-transplant maintenance therapy with a FLT3 inhibitor for patients who underwent allotransplant for FLT3 ITD AML is recommended except for patients with active acute GVHD. In the absence of an appropriate clinical trial, sorafenib could be considered as the preferred option, and maintenance should be initiated as soon as possible. Thank you for your attention. So now we can go for questions. So I have this question on the chat. First line midostaurin 3+7 and the Ratify trial is limited to patients less than 60. Do you use this molecule also in patients more than 60-year-old, knowing that these patients are not covered in the randomized trial, but only in a retrospective German analysis? Well, the answer is yes. We are currently using midostaurin during induction for all patients with FLT3 ITD-AML. So you can use other FLT3 inhibitors if you want, if you have access to quizartinib, etc. But I believe that in 2024, every patient with FLT3 ITD should receive a FLT3 inhibitor during induction, whether combined with chemotherapy or with hypomethylating agent and venetoclax. And we have seen, for example, the results with gilteritinib that are quite interesting from MD Anderson. I have another question, which is one of the most recurrent questions, I must confess, is how long would you give maintenance treatment? Well, we don't have strong evidence to give a clear-cut answer for that. I would say in the clinical practice, the position statement or guidelines of the ABMT Acute Leukemia Working Party. So based on expert opinion of multiple experts, the duration was a minimum of 24 months. The Chinese randomized trial used a shorter duration, and actually, despite the shorter duration, there was a benefit in terms of overall survival and relapse-free survival when using sorafenib. However, they observed also relapses occurring after stopping sorafenib maintenance. So I would say 2 years is a minimum if well tolerated. I wouldn't go below 2 years except for significant toxicity. After 2 years, well, it depends. If we are in CR1 and the risk of relapse is not very high. I think stopping at 2 years or between 2 and 3 years is quite reasonable. But again, these recommendations are based on expert opinion. And I know that there is a global effort currently to collect cases from different parts of the world to try to answer this question, because I doubt that there will be another randomized trial just to test the duration of sorafenib maintenance, how long it should be. Then I have a question from Dr. Enrico Morello. For a young patient in CR at allo, which inhibitor do you recommend? So I think that the question is about post-transplant maintenance. And I believe with the data that we have seen and in agreement with the practice pattern of more than 100 transplant centers in Europe in the ABMT, sorafenib is the recommended post-transplant maintenance. Sorafenib is the only inhibitor that has been shown to improve overall survival when used as post-transplant maintenance in 2 randomized trials in a registry analysis and in multiple single institution or multi-institutional studies. Conversely, we have numerical improvement with other inhibitors such as midostaurin, gilteritinib, or quizartinib, but none of them is associated with improvement in overall survival. So I would say that today in 2024, in the absence of clinical trial, sorafenib should be the recommended post-transplant maintenance. And again, it is not the activity against FLT3 that matters. We have seen that sorafenib can enhance and trigger a graft versus leukemia effect, which other inhibitors may not do, and explaining the benefit of sorafenib. So kinase inhibitors are not identical. So then I have a question from Dr. Clara Targetta. Would you use sorafenib as maintenance post-allo transplant also for TKD mutation? Well, this is a very difficult question, Clara. I would say that if we base our response on the fact that sorafenib does not target TKD, then the answer should be no. Sorafenib only targets ITD. It's a type 2 inhibitor and not a type 1 inhibitor. However, on the other hand, we have seen that sorafenib can improve outcome when used in combination with chemotherapy for AML patient without FLT3 mutation at all, and that sorafenib can induce a graft versus leukemia effect when used post-transplant. So the answer is maybe yes. I would not use sorafenib for TKD. We are using midostaurin. However, there is no evidence that it does not work. And finally, I have a question from Marta Lisa Batista. On the basis of morpho results in a patient with FLT3 ITD positive MRD at pre-transplant evaluation, would you use gilteritinib as maintenance after allo, or would you still prefer sorafenib? Well, I would give the short answer is yes, I would still prefer sorafenib. Gilteritinib in the subgroup of patients who are MRD positive pre-transplant improves relapse-free survival but gilteritinib did not improve overall survival. Whereas in two randomized trials, sorafenib use as post-transplant maintenance improves overall survival. So if we base our response on the improvement in overall survival, which is what matters most, sorafenib is the only one that improves overall survival, although sorafenib and gilteritinib can improve relapse-free survival in patients who are MRD positive. And the other troubling results in the Morpho trial are the fact that in Europe, for example, the placebo arm performed better than the gilteritinib arm, which is yet very difficult to understand. So the short answer is in MRD negative patients and in MRD positive patients, sorafenib should be the preferred post-transplant maintenance. It is the only one that improves overall survival. There was no evidence from the randomized trial that sorafenib will increase non-relapse mortality, whereas gilteritinib increased non-relapse mortality when used as maintenance in the Morpho trial. So we don't have questions anymore in the chat. I would like to thank you all for attending and for giving this time to this webinar of the International Academy for Clinical Hematology. And I wish you a good day or a good evening or a good night. See you soon.